So just to begin at the beginning, Alzheimer's disease was first described by Alzheimer. In about 1906, he had this patient who entered the hospital at age 48 or 49 and died when she was in her early 50s. There's a lot more to Alzheimer's dementia than loss of memory. And Alzheimer, in fact, you can read the description here, but you can see that she was having a great deal of difficulty, not just with memory, but with language, with understanding what people were saying to her, the last sentence is actually quite significant. She no longer remembers the use of some objects, by which he meant that you could put a toothbrush or a comb or a hammer or something like that in her hand, and she'd look at it, but she wouldn't have a clue as to what it was or how one is supposed to use it. And that's an intermediate stage, as our wonderful guest explained to us. Eventually people actually lose the ability, they essentially forget how to walk. And that is what really incapacitates people, how to speak and how to walk. So this is a horrible public health problem, which is a tremendous threat to the integrity of society. Alzheimer's disease causes dementia. It's one of many different illnesses that actually causes dementia. Dementia is global loss of abilities in cognition that's not caused by a dreamlike state or loss of consciousness. And it can actually have many causes, although Alzheimer's disease is the most common cause of dementia, accounting for something like 2/3 or 3/4 of all cases of dementia around the world. So I commonly get asked, what's the difference between Alzheimer's disease and dementia? And the answer to that question is that Alzheimer's disease is a disease of brain, we'll talk about it a little bit, that actually causes the dementia syndrome. Right now in Canada, there are 600,000 cases of Alzheimer's disease dementia. In the world, there are 35.6 million cases, and this number is expected to increase to 115 million cases by the year 2050, unless we can learn to prevent it. Okay? And it has huge economic and other implications for all societies. Right now, the worldwide costs of dementia are US dollars, $604 billion each year. Costs here in Canada, $33 billion. And between now and the year 2050, if you add up all the costs, the economic costs that dementia is going to cost us, a world, between now and then, the estimate is somewhere between 10 and 20 trillion dollars, which is an amount that is roughly equal to the gross debt of the United States right now that everybody is so worried about. And that's just from one cause, one condition, Alzheimer's disease. In the year 2050 alone, the estimate is that the world will be spending $2.3 trillion every year on Alzheimer care, unless we can do something to keep this from taking its natural trajectory. By 2050, almost 1 million Canadians will have dementia. By 2060, it's estimated that the costs of dementia care will exceed that of any other health condition. Here's an interesting statistic. By 2050, 24% of the Chinese population will be over age 65, and about 40 million Chinese will have dementia in one country alone. So we're looking at some really bad news here, okay? The point is that this is, on Wall Street they sometimes say it's baked in the cake. I mean, it is an inevitable consequence of the age structure of the population and the fact that our population is aging as rapidly as it is around the world, not only in the developed world, but also in the less developed countries. And this is going to happen. Depending on how old you are, substantial proportion of the people in this room will have dementia before the year 2050, unless we can learn to prevent it. So I like to tell people sort of the take-home message of what I'm going to tell them in a talk, and then at the end sometimes I tell them what I told them. And here are the take-home messages. First message: Alzheimer's disease is a chronic disease. So the dementia of Alzheimer's disease, as we'll see, is an end stage. It's like the tip of the iceberg, okay? And there's a lot going on before people actually get to that end stage. It's like cancer. Cancers grow for 20, 30, 40 years before they become obvious as cancers. Or heart disease, where we know now that there are changes in vessels that go on for many, many years before people end up with a heart attack or a stroke. The disease has a biology. It extends well into the decades before symptoms are seen. The more we learn about the disease, the more we will learn how to prevent or control it. So just like any other chronic illness, okay? And we will develop, certainly, better methods of detection and early intervention. And as we do so, doctors and nurses and others who are involved in the healthcare segment will certainly be looking more assiduously for this early signs of dementia. Now, number 5 here, we are on the verge of an explosion in knowledge about the biology of Alzheimer's disease and of its symptoms. But we're not there yet, okay? And in the meantime, it's very important for us to know what we can do now to try to help prevent Alzheimer's dementia. We can talk about that a little bit. Very, very importantly, number 7, prevention of Alzheimer's dementia can be achieved without preventing the disease itself. Now, what do I mean when I say that? Well, remember, this is a chronic disease that unfolds over decades, okay? And we can perhaps learn how to slow down the process, okay, so that the individual suffering with the condition still has Alzheimer's disease, okay, but has not yet developed dementia, and in many instances will die of some other unrelated condition before they develop dementia. That is prevention of Alzheimer's dementia without preventing Alzheimer's disease. And that, at least for the moment, is probably our greatest hope. And with research and resources similar to those that have been dedicated to other chronic diseases like heart disease and cancer, we should be able to achieve a similar measure of prevention and perhaps more. So now let's get into it a little bit. We know what Alzheimer's disease, I'm talking about the disease now, not the dementia, okay, what it looks like. These may be familiar to some of you. People talk about Alzheimer amyloid plaques. You see them on the left, or these strange-looking nerve cells that are sick and dying called neurofibrillary tangles. These are the hallmarks of the disease under the microscope. This is what Alzheimer himself described in his 1907 paper, in which he described his patient also that we talked about, okay? We don't know the cause, but we know a lot. We do know it's a chronic disease. As a chronic disease, like cancer and heart disease, it begins sometime in middle life, not in old age, but in middle life, okay? Its earliest symptoms typically are barely noticeable, and they may be viewed as normal for age. In fact, I would venture to say that that is the usual situation, that when people are in their 60s and 70s and maybe having just a tinge of forgetfulness, not all of those people are on the road to developing Alzheimer's dementia, but many are. Later, as the symptoms get worse, we have a condition that we refer to as mild cognitive impairment. Mild cognitive impairment we'll talk about in just a minute. It's a condition that now people actually have symptoms that can be compromising to their ability to function, but they don't actually have dementia. This slide is meant to show you graphically how the disease itself unfolds over a period of decades. So it begins with changes in the brain that we can see if we have the ways to examine the brain in life, okay? But there are no symptoms as such, and eventually, over some time, people do begin to develop some symptoms. Oftentimes, people actually notice subjectively that they're having some difficulty before other people can notice it. Sometimes it's the other way around. It moves along. Now we have this condition we referred to just a moment ago as mild cognitive impairment. And finally, this end stage, or tip of the iceberg, that we call Alzheimer's disease, dementia. This is the stage at which people have so-called mild cognitive impairment, or MCI. We'll talk about that for just a moment, okay? It means that there's a significant compromise in cognitive ability that leads to some difficulty in function, but the person is not demented. That means they can maintain independent daily activities, even though they may be somewhat compromised. And sometimes we divide this condition into memory predominant versus other forms of MCI where memory is less obviously impaired. And the amnestic type, the memory predominant type, is the one that most often evolves into actual Alzheimer's disease dementia. It's hard to know when someone is first entering this kind of condition exactly what's wrong. Sometimes people actually get better from this. Sometimes they stay the same. Sometimes they actually progress to the development of Alzheimer's disease dementia. But if you wait long enough, if people actually have MCI, or mild cognitive impairment, after 10 years, about 80% of these people will actually have developed Alzheimer's type dementia. It's important that we understand this because it enables us to give people advice and counsel and perhaps a little bit of encouragement, or at least explanation, early on in the course when they're struggling to understand what's going on, and to give them an idea of what the chances are that people will actually get better or not. So what we have to do is to try to look upstream into the stages of the disease where the disease may be present in brain, but the symptoms themselves have not yet fully declared themselves. Okay? We must find ways to attack the disease, in other words, in its pre-symptomatic stages, and prevent the emergence of the symptoms. Okay? So here we are back to our little graphic again. And you can see that what we're really talking about now is intervening at the stage that we're calling latent, as I've circled it here. Latent simply referring to the idea that the condition is present, but you can't detect it using the usual kinds of methods. One of the things that we can do is we can study changes or markers of brain changes that are present, as I indicated, before people actually have symptoms. So on this little graph here, this line right here shows the demarcation line between mild cognitive impairment, or mild symptoms that are not yet dementia, and fully fledged dementia. And you can see that there are some changes that we may be able to detect in the pre-symptomatic, or at least the MCI stage. This is cognitive performance. This is what we're used to looking at when we could think about Alzheimer's disease and similar conditions in old age, or as people get older, I should say. But there are other things that we can look at now to actually examine the state of the brain that change before people actually have symptoms. So here we've just put two up. The yellow line shows a specialized technique where we can put people in a special kind of brain scanner called a PET scanner, and we can look at a marker there of actual brain metabolic rates, and we can see that there are changes in brain metabolic rates that are taking place pretty well. before people actually have symptoms. Here we are at the stage of subjective cognitive impairment, but even back here in the pre-symptomatic stages, there are changes that we can measure if we look, okay? And likewise, we have less advanced techniques called MRI, which also shows changes, although perhaps not as dramatically as the FDG PET line that I just showed you here. And then we can measure things that are changing actually in the cerebrospinal fluid. This is the fluid that bathes the brain and the spinal cord, and it's as close as we can come to actually examining the chemistry of the brain directly. Okay, and this green line that I've drawn here shows something called cerebrospinal fluid tau protein. Tau, or abnormal tau protein, is a major constituent of those neurofibrillary tangles that I showed you a while ago. So the appearance of tau protein in the cerebrospinal fluid is an indication that people are beginning to develop these kinds of tangles, okay, which is in turn an indication of the fact that the disease process is underway, even though people don't yet have symptoms. And one more, and this is another protein called amyloid protein, which you can see, and it actually changes even before tau does. The whole point here is not to give you the full litany of exactly what changes when, but to show you how we can actually measure things and use them to study the progress of the disease process itself in people who don't necessarily have symptoms. In fact, in people who don't have symptoms, this is how we can evaluate whether we're giving people something that actually slows down or prevents the process. That's basically what we do in our center. Okay? So this is what I've just said. Biomarkers may be, we call these things biomarkers. It's a fancy word. It just means markers that show you the biology of the disease, right? Okay. And they may be useful for early diagnosis before dementia is evident, and there's a lot of emphasis on that now. People getting biomarker studies sometimes. They come in, they say, "Doc, I want you to tell me what my tau and my A beta are in my cerebrospinal fluid," and I say, "Why?" And they say, "Well, because if I'm getting Alzheimer's disease, I want to slow it down." And I say, "How?" It's a serious question. I mean, there's at this point, doing predictive testing like that in clinical practice is not particularly helpful. For research, it's another story altogether, because we can actually study the way this evolves over time, and perhaps even more importantly, we can study whether some treatment or intervention can change the rate at which it evolves, hopefully slow the rate at which it evolves, which, as I told you before, promises that we may actually be able to retard the emergence of the symptoms, perhaps even until the point where somebody has died of natural causes, in which case we've kept the person from developing Alzheimer's dementia altogether, which is really the name of the game. And that's what this slide basically is telling you. We can use these biomarkers to measure the effects of prevention strategies. Now, that's all very nice. If you come into our center, we'll be happy to explain it to you further. And if you have a mother or a father who actually suffered with Alzheimer's disease and you're healthy, we'll be happy to enroll you. And we brought along some brochures tonight, which I would encourage you to take with you and study if you're interested. That's for people who have access to specialized research programs such as what we offer here. But what about the rest of us? What can we do? What do we think we can do at this point to slow down the advancing progress of the disease? Well, the answer to that is we really don't know for sure. But what we can do is we can look at people in large numbers, and we can talk about some people who do this and some people who do that. and we can look and see whether people who do this develop Alzheimer's disease with greater frequency, or perhaps people who do that develop Alzheimer's disease with lesser frequency. So these are called association studies. Why? Because doing this is associated with greater risk of Alzheimer's disease. Doing that is associated with lesser risk of developing Alzheimer's disease. That does not prove causality, unfortunately, but at least we got a shot at it, okay? And doing that may be associated with reduced risk of Alzheimer's disease may actually even be good for you in other ways, so why not try to do it? So what can we do? What's the that? Well, we know, for example, that people who exercise regularly develop less Alzheimer's disease, okay? There are probably many different reasons for that. The exercise itself may have nothing to do with the Alzheimer's disease. It may have everything to do with cardiovascular fitness, which may in turn be what changes one's risk of Alzheimer's disease. We don't have a direct cause-effect kind of relationship here, but doing a little bit of exercise never hurt anybody, so we recommend it. And we know that people who exercise, on average, develop less Alzheimer's disease, so why not? Okay? Reduce your weight. I had delicious dinner before I came here, by the way, but control your blood pressure. I do control my blood pressure. We know that certain kinds of diabetes that are common in middle-aged and older people who are overweight and don't get enough exercise, those conditions are associated with increased risk of developing Alzheimer's disease. And we know what the risk factors for diabetes are. They are inadequate exercise, taking in too many calories, and having the wrong parents. Well, you can't do much about choosing your parents, but you can do something about the other two. So we encourage people to moderate their diet, exercise regularly. Starting to sound like a broken record? Okay, it's because it is. Improving their diet, not only in terms of how much you eat, but what you eat. So the so-called Mediterranean diet, which is a relatively lean diet with mostly unsaturated fats like olive oil, or starches that are not heavily fried in oil, not a very large amount of fatty meats, beef and lamb and things like that. You're probably familiar with this versus the typical, I'll say American, but unfortunately it's really North American diet, which is McDonald's and donuts. It's now been shown, and I'll show you some evidence for it, that eating a healthy diet actually is associated with reduced risk of developing dementia. So do it, okay? And this one at the bottom is an experimental treatment that may or may not help prevent the disease. We're actually testing that presently in our center. So let me show you a few data. Now, don't go to sleep. I'm not going to bore you with a lot of interpretation here. I'm just flashing these next few slides up here to show you that we actually have data on some of these factors. We're now beyond the realm of association and into the realm of experimentation. So we're actually manipulating things and looking to see whether it actually changes a person's metabolism or various manifestations of brain function or chemistry that are indicative that the person may be developing an Alzheimer type dementia. So I talked about exercise, right? Well, I told you about the association studies. Here's an experiment. We have actually taken people who are at some risk of Alzheimer's disease or dementia, and we've put them into two different groups randomly. One group goes to the gym and works out 3 times a week. The other group goes to the gym and does stretching exercises 3 times a week. Stretching exercises are great, but they don't have the same kind of health benefits as getting a vigorous cardiovascular exercise. And I'm not going to take you through the slide here other than to say to you, just to take it on faith, that there are differences, that the group that's assigned to exercise shows several different aspects of biochemical change that would suggest that they are in fact getting benefit from this and are likely to be developing Alzheimer's disease at least at a slower rate. Okay? We talked about diet. So we actually did an experiment, or I should say my colleagues did an experiment, where we took people and we assigned them at random to a prepared diet that was so-called Mediterranean diet in its food content versus a ghastly diet of fried foods and milkshakes, measured the effects over time on a cognitive test in this case, and you see the results here. I mean, again, I'm not going to go through them other than to show you that there are differences, that eating a healthy diet seems actually to help your cognitive ability in an experiment. That's the key, is that this is an experiment now. This is not just an association study. These are points that I already mentioned to you, but I will repeat them, because I think they're worth repeating. Chronic disease, similar to heart disease and cancer. It has a biology that extends well into the decades before symptoms are seen. As we learn more about the biology of the disease, and we talked about that a little bit, we will learn how to prevent or control it. Improved methods of detection and early intervention will undoubtedly motivate physicians and other health professionals to seek and treat early signs of the disease. But until we have more effective treatments, the benefits of that are going to be quite limited. However, we are on the verge of an explosion in knowledge about the biology of Alzheimer's disease and the prevention of its symptoms. Very importantly, prevention of Alzheimer's dementia can be achieved without preventing the disease itself. Okay? In the meantime, we do what we can to reduce risk, and with research and resources similar to those dedicated to heart disease and cancer, and we're about 1/10 that level now, we can achieve a similar measure of prevention and probably more. So now this time it really is the end, and we can